Thanks, Tony. So today, I've got to say I'm a bit nervous after following such a fantastic presentation from Keith, but here goes. So today I'm going to cover really the future work plan for IHPA rather than dwelling on the past. So I guess that really is around classification development, costing standards, benchmarking and different approaches to pricing. But just to recap, NEP 15 was released in March, and it's $4,971 this year, starting from 1 July, which was a 3% increase from last year once we took into account revisions to the data and methodology through our backcasting policy. And for those who are really interested in the deep detail, we had a 3% indexation factor. So as you know, we use historic cost data from 2012-13, and we have to project out into a future year, and we indexed at 3% per annum over the 3-year period. So classification development is a really crucial part of the work we do at IHPA, and it's one of the really strategic and long-term pieces of work over and above pricing. It's resource intensive, as many of you know, and lots of you have been involved in this work with us over the last 3 years. It relies on a lot of data, and a lot of the time the data isn't readily available and it's required some pretty big one-off studies, and it needs lots of clinical input and lots of review. And we're very lucky that we have a group of clinicians on our clinical advisory committee who have given us really good feedback on the journey we've been through. And some of our other groups, such as the ARDRG consortium, also have clinical advice. So making sure that all the work that happens in classification has strong clinical relevance. So mental health classification development is our really big project that's now well underway. We've just finished a costing study that was conducted at over 20 sites nationally. And you can see it covered most states and territories, and got a good spread of both metro and regional services. And for the first time, we also had some private hospitals involved as well. So we had 3 or 4 private hospitals. We covered admitted, community and residential services, and we collected cost and activity data on over 65,000 encounters. So it's been a really big study. Some of you are probably involved and still have the scars, but thanks very much to those who are involved. I think these things always end up being much bigger and much more complicated than we ever envisaged when we set out, but it's the only way that we can develop these classifications is through this really intensive data collection. The key data for the new classification, and of course this is still in development, so isn't locked in entirely, but there are 2 new data elements that will drive the classification. The first one is the phase of care, which is the prospective goal of care, which was collected throughout the study, and we're in the process of refining that definition, but it has shown to be a very strong predictor of resource use so far. Also the first episode of mental health care, so we know that is also a strong predictor of resource use. We're using a number of the items in the NOC data collection, so there's been a number of clinical tools collected for many years in mental health, including the HONOS, the life skills profile and the RUG-ADL. And for the study, we also collected interventions using the mental health interventions classification. So we've now got all this data, and we're probably about a third of the way through processing the data. And we've got, as you can see, very early schema for the classification. So at the moment, the drivers are the settings, so community, residential and admitted, and below that will be the phase of care. And under that, we expect a mix of things like age, HONOS scores, RUG-ADL scores. So, as I said, we're about a third of the way through that development cycle, and we expect over the next 2 or 3 months to get to a version 1, a draft classification that we will then pilot test and also have a public consultation process. So for those who are interested in this, I'd urge you to keep an eye on our website, and we'll of course be emailing stakeholders to invite them to have a look and give us feedback on the classification. But also, as I said, we will be pilot testing. We expect to pilot test in the second half of this year at 4 or 5 sites nationally, because we want to make sure, that it works and has good clinical relevance, and B, to really understand what the data requirements are and how big the change management exercise will be for data systems. Our other really big piece of work at the moment is teaching, training and research. So as people know, there's no classification system for TTR at the moment. And in fact, before we started work, there wasn't even a consistent definition of what we meant by TTR. So we've been through the foundational work. We've defined the scope for ABF purposes. We've carried out an evaluation of the cost drivers, and we're now established a data collection. So this year is the first year there'll be a national data collection on teaching and training activities, and next year will include research as well. And we've just commenced a costing study at 20 sites nationally. So in Queensland, Western Australia and South Australia participating. And again, I know there's a number of you in the room who are participating in that study, so thanks very much. We've learnt lots of lessons over our last 2 or 3 really big costing studies, so I think we've incorporated all those learnings into this one, and hopefully it will go smoothly. That runs for 6 months, so up until December, and we expect that classification development will start in early 2016. The emergency services classification, we're currently using the urgency-related groups in the vast majority of hospitals, the URGs. We've got 2 really big pieces of work. One is well underway, is the development of a diagnosis shortlist. So at the moment, people can use all of the ICD codes available to assign the primary diagnosis in the ED. And we're working on a project to cut that down to a shortlist. We're targeting around 1,000 codes. Again, it's been a very strongly clinically led process. And so thanks to all those clinicians in the room who have been bearing with us as we plough through chapter after chapter of the ICD. And we expect that will be complete sometime this year for implementation in 16-17. And that, we hope, will narrow down the real divergence of diagnosis assignment in the ED. And then just about to commences on Monday, is a ground-up redevelopment of the URG system. So that is based on the findings of a 2013 review, which I've talked about at previous conferences. And really the aim will be to better differentiate complexity in the ED. So we know URGs perform reasonably well, but we think there's significant scope for improvement. At the moment, for example, there's no complexity measures amongst patients with the same diagnosis groups. So we think there's a significant amount of improvement we can make there. And that will include a fairly short but fairly intensive data collection period. Obviously in ED, just because of the volumes, we think we can do that over a 3-month period. And that should be completed mid to late next year. So hopefully at next year's conference we'll have a very clear way forward on those 3 classification systems. The non-admitted classification, so as many of you know, and I'm sure you all love, the Tier 2 system is a clinic-based system. It doesn't differentiate complexity amongst patients at all. It is about which clinic the patient went to. And that was introduced in recognition as a balance between what data was available when we started ABF in 2012. And as we all know, non-admitted data is much more difficult and not nearly as robust as admitted patients. But we are just in the market now, looking to engage somebody to carry out this work, to develop a new non-admitted classification. It will use data from the 2013 costing study. So in that project, we collected costs as well as diagnosis and procedure information on about 500,000 patient service events. So we've got a really good database to drive that piece of work. But the big challenge will be is the investment that will be required in data systems. So we expect there'll be a fairly continuous consultation program on this piece of work as we start to design the classification and start to quantify what are those changes that need to be made in data collection systems and what the cost and lead time of those will be. ANSNAP version 4, which is used in subacute care, the redevelopment of that was completed in late 2014. We contracted the University of Wollongong to carry out that work for us, and again had significant clinical input. Includes new paediatric classes, so for the first time there's paediatric classes in ANSNAP. It includes impairment-specific weights to the FIM item scores for rehab. So previously, just the total FIM score influenced which class a patient was assigned to. We now have differential weightings on different elements of the FIM score, and all the information we have is that significantly improves the performance of the rehab arm of ANSNAP. For geriatric evaluation and management, based on significant feedback we got from clinicians, there's a better recognition of delirium and dementia, currently using ICD codes, but we've also got a fairly intensive data collection study underway to try and collect as much cognition tool data as we can in order to inform further refinement of the GEM part of the classification in future years. And finally, but certainly not least, is the DRG system. So ARDRG version 8 was again completed in 2014 at the end of the year. That work's been carried out by the Centre for Classification Development, led by University of Sydney, but in partnership with KPMG and the University of Western Sydney. The 9th edition coding, as I'm sure you all know, I hope, starts from 1 July this year, and training has been rolled out through the online process in the last few months. DRG version 8 is pretty exciting. I think last year I gave you an outline of the work that had been going on to totally rework the complexity measurement system, and also has much less reliance on administrative variables, so same day admissions or transfers or birth weight, things like that, although birth weight's still in. So there's much less reliance on administrative variables, much more reliance on diagnosis assignment, and we can see much better performance of this DRG system in the pricing model. So much better explanation of complexity, and we expect that's really going to make quite a difference in some hospitals, and planning and all indications are we'll be using that for NEP 16. So in the area of costing, we've got also a really big piece of work going on to rebuild the standards from the ground up. So this will be version 4 of the patient costing standards. The standards will be much more concise and very clear, and give much better direction on what our requirements are around standards, but also will importantly, and I think there's been a lot of feedback I've got over the last few years, will separate out business rules from standards. So there's a lot of things in the standards now that are around how the data should be reported or how it should be rolled up for the NHCDC. We're really looking to separate those out, recognising that the costing is a tool that's much broader than just the NHCDC. It's really there to manage, to help manage hospitals, and making the business rules for the NHCDC much clearer. It also includes a really extensive evaluation of cost allocation methodologies, which for people in the costing world, talking to you now, is very interesting and very important, and there's been great debate over the last 10 years about what are the best methods for cost allocation. We hope to get to a definitive position on that with the work we're doing now. We've heard a lot about benchmarking. People who were at the workshops yesterday. We saw a number of really good presentations on benchmarking, and as Jim alluded to in his presentation, we intend to establish a national benchmarking portal over the next year. So the aim of that is to allow all of you, jurisdictions, LHNs and hospital managers, to compare performance with peers, to really give people the ability to drill down to cost bucket level and understand where cost differentials are, to look at length of stay, to look at principal diagnosis. The proposal has strong support from most jurisdictions, so we expect that work will commence very shortly, and hopefully by the end of the year have a product that people can start accessing and comparing their performance against their peers. We've also had work going on for a number of years now, 2.5 years, on pricing for safety and quality, and how we could maybe incorporate that into our pricing regime. We've been working with the Commission on Safety and Quality in Healthcare on that, and have had a joint working party that has a very good clinical representation on it. And that's really fallen into two streams of work. One is around high priority complications, so how do we recognise in existing administrative data high priority complications, and also best practice pricing, which was inspired by the work you've just seen. So the Joint Working Party have developed a draft set of 39 complications that was developed last year and is available on the Commission's website. 36 of them we can identify from existing coded data, so through the admitted patient data set using the condition onset flag. 3 of them require new data development, so they're around things like MET calls and unplanned return to theatre. And we've currently got a proof of concept study underway in 4 hospitals nationally, which is looking at a number of things, including how well does the coded data align with the medical record, how well does the condition onset flag been coded, and how useful is this set of high priority complications to clinical groups in those hospitals. So that work is just wrapping up, and you should see the results of that work published in the second half of this year. Best practice pricing. I'm a little nervous now about trying to reduce a 45-minute presentation into one slide. Not surprisingly, we've been looking at fractured neck of femur patients. In terms of size, this is a sizable group of patients in the public hospital system. It's around 20,000 patients per annum and accounts for $250 million of expenditure. So this is a really big group, and we can have, we think, a lot of impact on this group of patients. As Professor Willett mentioned, we've been working with clinicians, particularly Jackie Close and Ian Harris, on this, and working through what best practice looks like. And it includes things like, not surprisingly, time to theatre, an orthogeriatric model of care, mental state assessments and early remobilisation. The data collection for this, as Keith mentioned, there's already a registry being developed, and our challenge, I guess, over the next few months is to work out how we can incorporate that registry information into our pricing approach. And we've certainly heard one really good way to do it today, and one that we're looking at very hard. So again, we think we will have a position where a plan to implement best practice pricing. We now need to work through the mechanics of how it's done and how that price would be determined. And lastly, is a reminder, I guess, for people that we do have our annual pricing framework consultation. The consultation paper for the 16-17 framework begins at the end of June. It's a really important document, this consultation process. It informs our pricing policy for the coming year. And it's a really important chance for you to influence the work of the authority. Submissions that are supported by data and by facts always are well received by the authority, always get a lot more attention. So I'd really encourage you all, if you've got things you want to raise with IHPA and about our pricing approach, that this is the best forum to do it. It'll be on our website at the end of June, and it runs for about a month. There's a series of questions around various things we're considering, but also, of course, always happy to hear of other issues you think we should be working on. And that's the end of my presentation.